dapat po munang alamin or matukoy ang pangunahing problema ng bansa upang mapagtuunan ng pansin at mabigyan ng solusyon.
We should have specific goals, do research, and make a policy that is fair for everyone.
Walang problema sa pulisiya. Iayos lang ang pagpapatupad.
Bago patubas ang batas, pag-aralan muna gusto ng government.
Two things, clarity and execution. Both, you need the communication and monitoring. As simple as that.
Mandato ng Philippine Institute for Development Studies o PIDS na gumawa ng mga pag-aaral at pananaliksik ng mga polisiya at programa ng pamahalaan at magbigay ng rekomendasyon sa mga mambabatas sa pagbabalangkas ng mga polisiyang makakatulong sa ating bansa. Sinusulong ng aming ahensya ang evidence-based policy making upang bigyan diin ng kahalagahan ng polisiya na batay sa datos at policy research na sumusuri sa tunay na kalagayan ng ating mga komunidad. Napakahalaga ng policy research, lalo na sa mga panahong dumadaan sa krisis ang ating bansa.
Kapag pulisiya ay pinag-aralan, susulong ang bayan!
In need of references for your research? Do you want a digital library that you can access for free anytime and anywhere? You don't have to look far. SERPI is here for you. SERPI is an online database of socioeconomic materials produced by the Philippine Institute for Development Studies, government agencies, research and academic institutions, and international organizations based in the Philippines. It is the country's first online repository of socioeconomic information, created for policymakers and development practitioners, researchers, educators, and students. To access SERPI, just visit the PIDS website and click the SERPI widget under the Databases tab, or type serp-p.pids.gov.ph. SERPI has a wide variety of materials such as journal articles, books, research papers, working papers, policy notes, audiovisual materials, and more. As of 2022, SERPI has more than 60 partner institutions contributing knowledge resources to the database. SERPI provides a comprehensive coverage of references encompassing 22 research themes: labor and education, gender and development, poverty, technology and innovation, trade and industry, and many more. On the enhanced website of SERPI, you can filter your research by keyword or author, publication type, research theme, or year published, all at the same time. SERPI has more than 7,000 publications and audiovisual materials that you can access and download for free. What are you waiting for? Visit SERPI now. Socioeconomic Research Portal for the Philippines, innovating knowledge exchange and policy research.
So what is PIDS? For over 40 years, the Philippine Institute for Development Studies, or PIDS, has been the country's foremost socioeconomic think tank. It conducts rigorous and objective policy research and analyses that help the government in crafting relevant policies, plans, and programs in support of the country's long-term vision and development goals. PIDS pursues its mandate through three basic programs: research, dissemination, and outreach. Through its research program, PIDS identifies and prioritizes studies, develops proposals, and conducts research on priority areas. The results of these studies are then disseminated through different platforms, publications, online resources, PIDS Corner, seminars, and the Development Policy Research Month, or DPRM, held every September. To shed light on key policy issues, the advice and expertise of the Institute's research fellows are also sought by policymakers, government agencies, private sector, and civil society. Since 1977, PIDS has completed numerous policy studies on a wide range of development topics. This brand of service has then translated to policies and programs that have improved the lives of every Filipino. Philippine Institute for Development Studies, service through policy research.
Dapat po munang alamin or matukoy ang pangunahing problema ng bansa upang mapagtuunan ng pansin at mabigyan ng solusyon.
We should have specific goals, do research, and make a policy that is fair for everyone.
Walang problema sa pulisiya. Iayos lang ang pagpapatupad.
Bago patubas ang batas, pag-aralan muna gusto ng government.
Two things, clarity and execution. Both, you need the communication and monitoring. As simple as that.
Mandato ng Philippine Institute for Development Studies o PIDS na gumawa ng mga pag-aaral at pananaliksik ng mga polisiya at programa ng pamalaan at magbigay ng rekomendasyon sa mga mambabatas sa pagbabalangkas ng mga polisiyang makakatulong sa ating bansa. Sinusulong ng aming ahensya ang evidence-based policy making upang bigyan diin ang kahalagahan ng polisiya na batay sa datos at policy research na sumusuri sa tunay na kalagayan ng ating mga komunidad. Napakahalaga ng policy lalo na sa mga panahong dumadaan sa krisis ang ating bansa.
Kapag pulisiya ay pinag-aralan, susulong ang bayan.
In need of references for your research? Do you want a digital library that you can access for free anytime and anywhere? You don't have to look far. SERPI is here for you. SERPI is an online database of socioeconomic materials produced by the Philippine Institute for Development Studies. Government agencies, research and academic institutions, and international organizations based in the Philippines. It is the country's first online repository of socioeconomic information, created for policymakers and development practitioners, researchers, educators, and students. To access SERPI, just visit the PIDS website and click the SERPI widget under the Databases tab or type serp-p.pids.gov.ph. SERPI has a wide variety of materials such as journal articles, books, research papers, working papers, policy notes, audiovisual materials, and more. As of 2022, SERPI has more than 60 partner institutions contributing knowledge resources to the database. SERPI provides a comprehensive coverage of references encompassing 22 research themes: labor and education, gender and development, poverty, technology and innovation, trade and industry, and many more. On the enhanced website of SERPI, you can filter your research by keyword or author, publication type, research theme, or year published, all at the same time. SERPI has more than 7,000 publications and audiovisual materials that you can access and download for free. What are you waiting for? Visit SERPI now. Socioeconomic research portal for the Philippines, innovating knowledge exchange and policy research.
So what is PIDS? For over 40 years, the Philippine Institute for Development Studies or PIDS has been the country's foremost socio-economic think tank. It conducts rigorous and objective policy research and analyses that help the government in crafting relevant policies, plans, and programs in support of the country's long-term vision and development goals. PIDS pursues its mandate through three basic programs: research, dissemination, and outreach. Through its research program, PIDS identifies and prioritizes studies, develops proposals, and conducts research on priority areas. The results of these studies are then disseminated through different platforms, publications, online resources, PIDS Corner, seminars, and the Development Policy Research Month or DPRM held every September. To To shed light on key policy issues, the advice and expertise of the Institute's research fellows are also sought by policymakers, government agencies, private sector, and civil society. Since 1977, PIDS has completed numerous policy studies on a wide range of development topics. This brand of service has then translated to policies and programs that have improved the lives of every Filipino. Philippine Institute for Development Studies, service through policy research.
Welcome to the PIDS webinar series. Before we start our virtual event, we have some reminders. For attendees, your microphone is automatically muted upon entry. If you wish to join the discussion, click the Q&A icon, type your question, and click Send. For Facebook viewers, you may send your question using the comment section. Remember to keep your questions concise and direct to the point. We will screen all questions to ensure that they are relevant to the webinar topic and the presentation. The moderator will read the questions during the open forum and cover as many as possible depending on the available time. This webinar is being recorded and live streamed on the PIDS and SERPI Facebook pages. The recording will also be made publicly available on the PIDS YouTube channel. Thank you for joining us, and we look forward to your active participation.
Good afternoon, everyone, and welcome to our webinar featuring the PIDS study titled Spatiotemporal Analysis of Health Service Coverage in the Philippines. I am Sasa Esguera from the Public Affairs Division of the PIDS, and I will be your MC for this afternoon's webinar. The study we will feature today analyzed the health service coverage and financial risk protection provided to members and their dependents by the Philippine Health Insurance Corporation, or PhilHealth. Using a unique combination of PhilHealth data from 2018 to 2021 and the supplementary information from the Department of Health, Philippine Statistics Authority, and the Washington-based Institute for Health Matrix and Evaluation, the study identified location-specific patterns and insights. During this webinar, we aim to gain a deeper understanding of the equity in health service coverage across the Philippines and identify strategies to bridge any existing gaps. In addition to our distinguished presenter, we are privileged to have 3 discussants who will share valuable insights derived from the study. Now, to formally open our program, may I call on our PIDS President, Dr. Aniceto Arbeta Jr. to give his opening remarks. Dr. Arbeta, over to you.
Thank you, Sasha. Good afternoon, everyone. And thank you very much for joining us today for another PIDS public webinar entitled Proving Healthcare Disparities, Trends and Insights Based on PhilHealth 2018 to 2021 data. First, allow me to greet the following officials. Bulacan State University Vice Chancellor Cecilia Hieronimo, Department of Science and Technology Director Romeo Ongpoy Jr., House of Representative Director Dominador Gamboa, Lorma Community Development Foundation Incorporated Executive Director Andrew Cesar Rimando, Mental Health PH Co-Founder Yves Mil Zuniega, National Academy of Science and Technology President William Padolina, National Economic and Development Authority Regional Director Maria Felicidad Guerrero, National Institutes of Health Director Raymond Francis Sarmiento, Philippine Health Insurance Corporation's Regional Vice President Danilo Reynes, and Una Hakbang Foundation Incorporated President Oli Lucas. I would also like to greet those watching through our PIDS and SERPI Facebook pages, especially from various government agencies, local government units, academia, civil society, and media. The evolution of the Philippine healthcare system has been in place since the enactment of the Local Government Code in 1991. This devolution tasked local authorities with overseeing and providing various healthcare services. These services encompass a wide range of responsibilities, including health education, managing locally prevalent diseases, immunization initiatives, reproductive health services, nutritional support, distributing vital medications, and maintaining environmental sanitation standards. Additionally, local governments are entrusted with the operation of healthcare facilities, which include primary healthcare centers and hospitals, along with the delivery of associated medical services. In a 2018 study conducted by former PID Supervising Research Specialist Janet Cuenca, she revealed lessons learned from more than 25 years of this experience. She noted that health devolution has led to a fragmented public health system and that implementing health reforms in a decentralized environment was challenging. While it aimed to provide local health services promptly without higher level intervention, it also raised issues of political capture, corruption, and misuse of funds. Although government has made various strides in our healthcare system, striking inequities continue to exist due to unresolved challenges in access to healthcare, especially between rural and urban areas and between socioeconomic groups. In 2019, the government took a significant step to address the challenges in the healthcare system by enacting the Universal Healthcare Act. Under this reform, the Philippine Health Insurance Corporation, or PhilHealth, serves as the national purchaser of individual-based health services, focusing on financial protection for Filipinos seeking healthcare. However, challenges persist. One study of PIDS found that PhilHealth contribution to the country's total health expenditure remains limited, leading to a reliance on household out-of-pocket spending. The proportion of expenses that PhilHealth can cover decreased from 32% to 32% in 2020, from 59% in 2015 for private hospitals, and 15% in 2020, from 43% in 2015 for public hospitals. These harsh realities emphasize the immediate need for a more equitable healthcare system that is accessible to everyone, leaving no one behind. It is in this context that we feature the study Spatiotemporal Analysis of Health Service Coverage in the Philippines by PID Senior Research Fellow Valerie Gilbert Olive, Supervising Research Specialist Jana Uy, and Research Consultants Clarissa Joy Flaminiano, Vicente Alberto Puyat, and Victor Andrew Antoni. The study evaluated the PhilHealth members and dependents' health service coverage and financial risk protection, providing recommendations to address disparities in population coverage, facility coverage, service coverage, and financial protection across different subpopulations. House of Representatives Committee on Health Chairperson Honorable Ciriaco Bigato Jr., Philippine Alliance of Patient Organization President Karen Villanueva, and PhilHealth Primary Care Policy Vice President Albert Francis Domingo are joining us to provide valuable insights. I wholeheartedly urge all of you to approach this presentation and ensuing discussions with curiosity and open-mindedness. Your active engagement during the forthcoming open forum is highly encouraged. Let us collectively harness the potential of this webinar to foster a robust and insightful conversation grounded in empirical evidence. Again, good afternoon and thank you for joining us today. Back to you, Sasha.
Thank you, Dr. Arbeta, for giving us a glimpse of the topic that we will discuss today. Now, before we dive into the studies discussion, let's kick things off with a brief poll to gauge the sentiments of our participants. All right? So we have a poll question sa screen po ninyo, flash on your screen. And the question is, how satisfied are you with the health service coverage in the Philippines? Again, how satisfied are you with the health service coverage in the Philippines? To answer the poll, you may click on the link on the chat box or scan the QR code on your screen. For our Facebook viewers, we also encourage all of you to join our poll. You may also click on the link in the comment section dyan po sa ating Facebook live stream. Alright, so you have 5 options po no, sa ating poll question. We have very satisfied, satisfied, neutral, dissatisfied, or very dissatisfied. Alright, so siguro naman po meron na tayong mga ano dyan. Team, can we see the Mentimeter result? All right. Sige, let us wait for our team to present the result of our poll. But based on dito sa aking screen, dun sa nakikita kong result natin, 62 respondents, we already have 63. Ayan, 63 respondents and majority, ayan, nakikita na. Hi everyone, I apologize for that. Medyo nag-freeze lang yung aking screen. But I'm back and let's see the Mentimeter result. All right. So as I've mentioned earlier, we have parang majority of our respondents answered dissatisfied, no? And humahabol yung neutral. Ayan, medyo humahabol yung neutral. We already have 70 respondents. And maybe etong response ng ating mga participants today ay kakonekta ng mga issues and challenges na ipepresenta ng ating presenters no, mamaya sa discussion natin later on. Alright, para medyo mas makita na natin or mas tuloy-tuloy na po tayo sa ating discussion. At this point, I'm delighted to introduce to you our PIDS Research Information Department Manager, Dr. Sheila Ciar. She will guide us in introducing our presenters and speakers and will also lead the discussions during our open forum later. And we also anticipate your continued engagement during our open forum. No? Dr. Sheila, the virtual floor is now yours. Thank you.
Thank you very much, Sasa. Indeed, very revealing yung results ng ating poll. And yes, you're right. Mas maliliwanagan tayo sa mga presentations no kung bakit ganun yung sentiments no ng ating participants and the presentations today will provide empirical analysis no of our topic on probing healthcare disparities and hopefully sa discussions natin ngayon mas maiintindihan natin yung mga current challenges and also we will be able to come up with recommendations on how to address existing gaps. Okay, so at this point I am delighted to introduce to you our presenters. As mentioned by Dr. Orbeta this afternoon, we will be featuring a PIDS study and the said study is entitled A Spatial Temporal Analysis of Health Service Coverage in the Philippines, which was authored by the following. We have several research consultants of PIDS who are behind this study. They are Ms. Clarissa Joy Flaminiano, Mr. Vicente Albert Puyat, and Mr. Victor Andrew Antonio. And we also have, as part of the research team, Ms. Jana Uy and the project director, Dr. Valerie Gilbert Ulep. And to present this study is Dr. Ulep. Dr. Ulep is Dr. Valerie Gilbert Ulep is a senior research fellow at the Philippine Institute for Development Studies. He's currently the director of the institute's research projects on health and nutrition. He is also a senior researcher at the Ateneo School of Government. And before joining PIDS, he worked at the World Bank and its DC and Delhi offices. He was a doctoral fellow at the University of Toronto Center for Global Health Research, where he conducted economic studies on tobacco taxes. He has provided technical assistance to the World Bank, the Asian Development Bank, and World Health Organization Center for Global Development, and the United States Agency for International Development. Dr. Ulep is a recipient of several awards, including the Nikkei Asia and the Global Voices for Global Health. Emerging Voices for Global Health. He has a PhD in health economics from Canada and a master's degree in epidemiology. Dr. Val Ulep, the floor is now yours.
So, hello, can you hear me?
Yes, we can hear you.
So, thank you, Ma'am Sheila. So, hi, everyone. So, before we start the presentation, I want to thank my colleagues at PIDS for organizing this public seminar. I'm presenting our working seminar, or our working paper, I should say, from last year. And I would like to first acknowledge my co-authors for this work. First, Jana Uwe, our supervising research specialist, for helping us with the data. Clarissa Flaminiano, one of our consultants who helped us with also cleaning the data and doing the analysis. Vito Puyat, who's now doing his master's at Harvard, and Dr. Antonio of Ateneo. So our presentation is about geospatial analysis of effective or service coverage in the Philippines. So in this paper, or in this study, we want to understand the performance of critical PhilHealth indicators at a more granular level. So next slide, please. So before we go into the objectives and the result, I just want to go through the premise of this study. I'm explaining what really motivated us to conduct this study. So by the way, this study was an in-house study of PIDS. It was not funded by PhilHealth, DOH, or any multilateral organization. It was funded by PIDS. So to me, there are three main motivations of this study that we need to highlight. Number one is there is limited granular analysis or deep dives of health services coverage by PhilHealth. When I say PhilHealth, our national purchaser, I don't want to use the term insurer because PhilHealth is our national purchaser. And this study aims to, and I think the study hopes to pave the way for more exercises like this, because we barely see these kinds of granular analysis. No? So if you go to PhilHealth website, you will only see, national estimates, or kung swertehin may regional estimates. No? And this one, we try to go at a more granular level, at the provincial level, but we initially aim even at the municipal level during the conceptualization of this work. No? As I said, in a highly decentralized setting like the Philippines, granular level data is very important. And yeah, we want to see more granular analysis because this actually helps us design better or public policy. Second, the other motivation of this is, as we may know, the Philippines is in a major health reform, which is the UHC law, which attempts to integrate or reimagine the role of provincial level government through a more integrated and systematic care. Hence, I think it's important now to start looking at provincial level estimates, or provincial level performance estimates on equity, for example, or efficiency in providing healthcare services. Third, another aim of this is to actually inform PhilHealth about the need to exploit the richness of data to inform operations, not only policy, but operations. So this is the first study to be released that uses this data set. No? Currently, at PIDS, we are also using this data that we assembled for months and months to inform, for example, the base rate and adjustment of the diagnosis-related groupings, or DRG, which we are also helping, and examine the financial health, for example, of hospitals in the Philippines. So this is just one of the studies from that data set that we generated a few months ago. So next slide. Okay, now let's address why this study is relevant. We need to discuss why this study is relevant, and what is the policy question that we are trying to answer in this presentation or in this paper. So if we look at our policies in the Philippines, it is safe to say that we are among the most progressive. Like, even if you look at, for example, our ASEAN neighbors, if you look at the written policies, I think we are the most progressive, whether by design or by chance. If you look at many articulation of the law, there are so many cross subsidies and supposed investments towards the poor. Even if you look at the NHIP, that's you will see there a lot of stipulations on the high level of progressiveness of our health policy. So the National Health Insurance Program Act of 1994 highlights these progressive policies, aiming to provide equal access to healthcare services and give priority to vulnerable segments of the population. So the motivation really of this paper is that while the policies articulate progressive goals, this needs to be reflected in its performance. No? And if you look at, we have conducted many studies in the Philippines, you see high inequities in health outcomes in the Philippines. And to me, there is a paradox in the policy articulation and the actual performance, right? So this is what we want to really highlight at a more higher or macro level. So the policy motivation for this paper is, we really want to show that. So next slide. Okay, so what do I mean by this? No? So here, the health outcomes in the Philippines are, I would say, a microcosm of global health inequities. No? So the poorest regions, for example, ARM and some part in some parts of Visayas, their health outcomes tend to have their health outcome is actually similar to the poorest regions and countries in the world, like sub-Saharan Africa, for example, right? You will see the infant mortality rate, right, is comparable to some countries in sub-Saharan Africa, while in richer regions like NCR, it's actually it's similar to many emerging economies, right? Like similar to Thailand or Malaysia, etc. So there is really a wide disparity in terms of health outcomes. So this is very telling because it implies that the inputs, your resources, your capital investments, your equipment are not distributed based on need. When I say based on need, that could be resources or that could be health outcomes. So there is a disconnect in terms of the distribution of inputs, no? Whether it be capital investments or human resources, etc. So next slide. So what is the objective of the study? So here we evaluate PhilHealth healthcare service performance across 3 domains. So number 1, population and facility coverage. So focusing on NHIP's covered population and accredited health facilities. So the analysis explored the optimization of service availability and accessibility. Another one is service coverage. So we're understanding admission rates, utilization rates, and other related indicators. And the last one is looking at financial protection, assessing proportions of healthcare costs covered by NHIP. So popularly called the support value, etc. So we want to look at financial protection at the provincial level. Okay, next slide. Okay, before we go into the results, I want to briefly describe our analytical framework or approach which guided our analysis. So those who are working in the health financing arena, you are, I'm sure, familiar with this framework. which looks at different aspects. So number one is availability of coverage. So is the service available? Then when you answer that, you need to look into accessibility, right? Is the service accessible, then acceptable? Who are the people using the services? So that's your contact coverage. Then the next level question is, are the services being provided are effective? It's not just enough that you're giving the resources, but thinking about whether these services are effective or not, right? Otherwise, it will not have impact on outcomes. So we try to map out possible constructs or indicators under each of this framework, right? So under access, like who can access services? Like we look at population coverage of PhilHealth. Number one is under available access. We examine access to accredited facilities or hospitals. Under contact coverage, or we examine utilization rates because that measures who are using the services. We also estimated admission rates and ambulatory care sensitive indicators. And under effectiveness, although we have a lot of indicators of effective coverage, but for this one, we are using the financial protection, which is support value, given that's the only construct or variable that we see in the PhilHealth data. Next slide. Okay, so I'd like to emphasize that the health data in the Philippines is highly, highly fragmented, making it very challenging to conduct a nuanced analysis due to this fragmentation. And when we were doing this study, we dedicated around, I would say, 80 to 90% of our time cleaning and merging the data, right? It's 80 to 90% of our level of effort time, no, in cleaning the data and preparing for analysis. So 80 to 90%, right? So this table just shows you the different data that we use. We use the million data claims from PhilHealth, the health facility data, the e-claims of data of PhilHealth. This is also million data points. The Philippine Standard Geographic Code to merge the non-health data. We use poverty statistics, and we also borrowed the global burden of disease grouping for us to see that, for us to translate the ICD, but I'll not go through that. Next slide. So in terms of processing, we attempted to merge this big data, this data set. So we started with the PhilHealth data, membership, accreditation data, e-claims, and we merged the data from DOH, the National Health Facility Registry. Then we also merged the PSA data, the census and population and housing, the poverty statistics, and we also merged the IHME data for the ICD-10 code. Next slide. Okay, I'll start with few of the results because it's impossible for us to like go through the results of this study. So I just pick up one of the most relevant one. So number one, so we look at access and availability. So here we examine membership in accredited facility across provinces, focusing on inpatient services due to limited outpatient and primary care information. So here we just look at the coverage rate, and we try to look at its relationship with poverty incidence and things like those, and those kinds of analysis. No? So next slide, please. So I'll start with with the coverage rates, or as one indicator of access. So we'll delve into some intriguing policy relevant points about the UHC law in the Philippines and its implication for coverage. So as you may know, PhilHealth, if you look at the 2019 UHC law, like Filipinos are automatically enrolled in the National Health Insurance Program, so ensuring 100% coverage. So this is a very fundamental shift or milestone in the country's healthcare system. So we tried to look into the data, whether this is we are achieving this, or if the data really reflects this. So using the 2020 data, the country achieved a very high population coverage with PhilHealth extending health insurance benefits to most Filipinos. So you can see the left here, just for presentation, the different coverage rates across regions, across islands. So on the right side, that's the provincial level estimates. No? And the right side indicates that it's predominantly green. No? So which highlights that there's a vast proportion of the population across provinces is now registered in the PhilHealth database. However, if you look at individual provinces, there is spatial disparities. There's still differences in terms of coverage rate across provinces, with certain provinces in Mindanao, for example, reporting 52% of 50% coverage rates. Notably, these provinces are often considered conflict areas, and poorer provinces. No? So in the paper there's analysis looking into the poverty incidence of and its relationship on the coverage rates. No? So again, this presents a unique challenge for PhilHealth. The low registration in these areas underscore the need for targeting efforts to enhance membership registration and healthcare access. No. And as you can see, the right figure, the huge differences in coverage rate, and you will see the lower level coverage rate in Mindanao. Slide 11, next slide. So here we just wanted to see the distribution of or the type of contribution or the type of membership across the coverage rate. So around if you look at this data, around 71% of the people in Greater Manila areas are direct contributors. These are formal, informal economy. You know, membership breakdown in Luzon and Visayas is fairly divided between direct and indirect contribution, while Mindanao has the largest share of indirect contribution, no? Mostly indigents, or 57%. No, so I think the policy question there is that, so what is the implication of this high level of indigents in areas like Mindanao? So I think it's obvious, but from an operational perspective, what's the implication of this? Are there implications, for example, on the political economy of central and local governments, and how about in terms of access? Will there be variation in terms of access when you have variability in the share of contribution, right? So, but you might not see any significance of that, right? But in this paper, I think I'm not presenting here, we have also attempted to explore coverage rates specifically for women, for children, and I think these are critical analysis using this microdata to see the coverage rate of vulnerable population. This will determine whether we have provided access to the most vulnerable segments of the population. Next slide. So here, I will go through the facilities, so facility coverage. So as you may know, the DOH mandates, or maybe this is a customary standard, the DOH mandates a bed to population ratio of 1:100. So the median accredited hospitals, the bed density in the Philippines was about around 0.08. So that's actually below that standard of 1:1,000. So we're only at 0.8, right? So again, with variation across different island groups, as Metro Manila approach these 1:1,000 bed ratio, while Luzon and Mindanao had the lowest median bed density. So we also examined the disparities and the distribution of hospital capacity by ownership. I'm not showing in this report, revealing significant variations in the presence of the private sector or the penetration of the private sector across provinces, and the availability of the different services, level 1, level 2, private or public. No, there's a significant distribution across provinces when it comes to the type or the ownership and the level of services, hospital services. So and I think this signifies the large large market segmentation of services, no, of the private sector across provinces, and it's highly linked to income and other socioeconomic predictors, no, of this segmentation. Again, so this analysis shows the choices between private and public healthcare providers, particularly among children and women. So it's not here in the analysis, but it highlights. So these kinds of analysis help us understand where children goes or women goes when it comes to, or women go when they need healthcare services, private, public, etc. So these kinds of these kinds of data set will allow us to see those trends, though. When it comes to access. Next slide. So next is we are now in contact coverage, I think. So we are now on contact coverage. So when we say contact coverage, we are looking at the question, who are using the healthcare services? So when you are covered, the next is, are you using the healthcare services? So that's what we want to see in this domain. So next slide. So here on the left side, we calculated the admission rates per 1,000 population, which again shows a great variation in provinces. So we are still working on this. Why we're seeing the large cluster of provinces with admissions rate of around more than 50 admissions per 1,000 population, for example, in Mindanao. No? And we are seeing higher rates of admissions in poorer areas. So we're still trying to figure this out. Why is this so? But I think this is actually a different pattern compared to other countries where you see higher admissions rate among those who are among richer provinces, for example. So is this positive? So this is the result of positive development, indicating improved access among the poor. Does it show or is a reflection of inefficiencies, etc.? So again, this requires a more or in-depth investigation, examining, for example, the burden of disease in these areas and the disease patterns in these areas to see to have a more comprehensive analysis. Why do we see higher admission rates in some provinces, particularly in Mindanao, right? Next slide. We also wanted to see the patterns of disease by NCDs. We wanted to see NCDs because this is actually a litmus test for an effective or efficient primary healthcare services, right? So we really wanted to see what's happening with our admissions when it comes to NCD. So NCD is a tracer indicator of a well-functioning primary healthcare or an efficient health system. So here, what we've seen is that there is high NCD admission rates, especially in Mindanao. So we've seen higher admission rates on NCDs in Mindanao, and we've seen higher rates in children and in mid-age adults. So again, why are we seeing these patterns? Again, what explained this phenomenon? So are there numerous? So if we try to step back, so maybe these admissions primary results of NCDs or higher risk factor of NCDs? And if so, does this reflect, for example, the burden or availability of primary care facilities in the area, or the absence of primary healthcare services that may lead to unnecessary admission? So I think my hypothesis here is that, do we see higher NCD admission rates in areas with poor PHC, for example, because they are forced to go into hospitals, right? So we've seen in these patterns in many countries in South Asia, for example, where they're going to hospitals because there's no primary healthcare, right? So we need to see those patterns, right? Next slide. I think I'm running out of time. Next slide. So we also examine the ACSC admission rates. What do we mean by ACSC? So ACSC is an ambulatory care-sensitive conditions. So these are health conditions like asthma, right, or pneumonia, for which an effective primary care, for example, can help prevent this hospitalization or complication. So with a strong primary care, you can avert all avert majority of these ACSC, like pneumonia, asthma, hypertension, and things like those. No. So when we examine PhilHealth data, around 33.6% of admissions fall under ACSC. So potentially you could actually avoid these admissions when you have a more efficient or effective primary health care, right? So again, there is variation in terms of ACSC admission rates, but I guess this is very telling that most of our admissions could be actually prevented. So instead of us building more specialty hospitals, you can actually invest more on primary healthcare to catch all these unnecessary admissions to begin with, right? So there is that kind of narrative in this indicator, right? Next slide. So yeah, but just to reinforce that 33% is very high. So I think in Vietnam, for example, the ACSC is actually lower than 30%, right? So, but again, ours is very high now. So last one is effective coverage. In this case, we look at financial protection. So here we're just measuring support value. What do you mean by support value? So of the total bill, how many percent was covered by PhilHealth, right? So that's basically the effect, the measure that we use here, and we call it support value, right? Next slide. So here I just look at the disaggregation. So on average, the support value of PhilHealth around 60%, with significant variation across location, across facilities, across membership. And I just want to highlight the support value for indigents. Actually, it's not even reaching 80%. Right? So, and you are not counting the indirect costs here, like pamasahe and everything. But these are just direct medical costs, right? So again, we're not. We can see a lower level of support value among certain segments of the population. Next slide. Also, the left map shows you the support value across provinces. Again, there's variation in support value, which could be a function of your the presence of private sector, etc. Etc. So on the right table, we also measure the support value by disease. Again, it varies. It's highly unpredictable. There are support value of 30%. Such as diabetes to 50%, for instance, lower respiratory tract infection. But again, it's still around 50%, at least for these specific diseases. Okay, next slide. Okay, just want to summarize. So as I've said, we look at different indicators of access and available coverage, and you see, despite the high level of coverage overall, there's still hotspots of undercoverage. Again, on contact coverage, admission rates, you will see variability also. But you're seeing higher level of admissions in some parts of Mindanao. And in terms of ACSC, there it's actually very high. So the type of services that being used are mostly on high, or a big chunk of that is non-communicable diseases. And effective coverage around 60%, but it could go as 30% for some diseases. Okay, so next slide. I think I'll just I think I'm running out of time. I just want to say something about the policy recommendation and what possible actions that we could get from these findings. So number one is enhancing data to inform policy and operations. So how can data inform our actions? For instance, we can use data to identify disparities and inefficiencies in service provision. Through a more granular level, we can determine if system is inefficient, or not. No? And we need to actually look into these granular data and link them with other non-health data. We need to see those things. Or how can we use data to benchmark provinces, the performance of provinces? How can we use these data to benchmark hospitals, right? So in many countries like the UK, they use this information to benchmark the performance of one hospital to another, right? How can we use these kinds of information to improve efficiency, right? And yeah, how can we use this information to incentivize facilities, to penalize them, etc. So we need to use these data to drive policy and operation. Second is addressing supply challenges to reduce these disparities. So how can we reallocate our national resources? Like, for example, HFEC. How does data guide capital investments and equipment choices? Are we using activity rates, for example, or admission rates to inform what equipment to buy? How many beds are going to build, etc. So how can we use these kinds of these things? Another one is enhancing demand, right? By improving primary healthcare. So as you can see, the Philippine health system is very hospital centric, no? So, and as you can see by the high level of ACSC, so the lack of robust primary healthcare in the Philippines contribute to this higher hospital admissions, no? So the absence of outpatient benefit package in hospitals actually leads to more admissions in hospitals, right? So there is also need to reevaluate whether our PhilHealth policies are actually exacerbating this hospital-centric admissions, right? For example, the lack of outpatient benefit in hospitals forces government to actually admit, non-severe patients, right? Like even if you have pneumonia that you could just be treated right away, hospitals are forced to admit them. Like we haven't thought about these things, but these are perverse incentives of the policies that we've chosen, right? So how can we make our hospitals efficient and not building more specialty hospitals? Although we still lack a lot of specialty clinics, eye hospitals, but there is a mechanism for us to be more efficient, right? And obviously, how can we fast track the implementation of primary healthcare? And I hope Dr. Albert could enlighten us on that front. But I think this presentation is about making our health system more efficient, and going back to the basics. How can we improve primary healthcare so that our hospitals will be more efficient, right? So we need to look at this as a whole system, not in silos. So I think those are just my broad policy recommendations, but we can go on the specifics during the discussion. So thank you very much.
And thank you very much, Dr. Val Ulep, for that thought-provoking presentation. And thank you also to your team. Congratulations for that comprehensive study. Well, you can download the full study from our website. And I think the link has also been is also available on our chat box, as well as in the comment section of our Facebook page. So Dr. Val Ulep has shown us some very encouraging results, but admittedly there are some disturbing findings in terms of population coverage, service coverage, and the financial risk protection provided by our national health insurance program. And in the next part of our conversation, we will have the comments of our discussants. And as mentioned by Dr. Arbeta in his opening remarks, we have 3 discussants. And the first one is from PhilHealth. Well, we are talking about the services of PhilHealth, and I think you will agree with me that our conversation today will not be complete if we will not hear the comments of PhilHealth. And we are very honored to have with us today the Vice President of PhilHealth, Dr. Albert Francis Domingo. Dr. Domingo is a physician and health system specialist with 15 years of experience in the country and at the country and international levels, including working with the World Health Organization the Asian Development Bank, and the United States Agency for International Development. Dr. Domingo specializes in various health areas, including non-communicable diseases, reproductive health, TB, HIV/AIDS, and emergency response, such as the COVID-19 pandemic. Currently, he serves as Vice President at PhilHealth, overseeing primary care policy and acting as Head Executive Staff of the Chairperson of the Board of Directors. Dr. Albert Domingo, sir, the floor is now yours.
Thank you so much, Dr. Sierra, Ma'am Sheila, and greetings to Dr. Orbeta, and of course, Ms. Sasa Esguerra, and the authors, Val, Dr. Ulep, Ms. Flaminiano, Mr. Puyat, Mr. Antonio, and Ms. Uy. That really was a provocative presentation, but then again, I'm not so... So yeah, I thought I was on mute. All right. I'm not so provoked, shall I say, because we already know a lot of the stories over there. But what really got me interested in this study is the fact that there is a heat map. There's a geographic localization of the findings. And I think, well, I have quite a few notes to share, but I would like to point out that this is most useful because in the scheme of universal healthcare, it's no longer about national averages. It's about local performance. It's about making local health systems well-resourced and accountable for their own actions. How can we exact accountability if we don't have attribution? And how can we expect action if we will not base our assistance on what our findings will be on this attribution of both good findings and also problems that need to be addressed? So let me begin with a rundown. I was listening intently to Dr. Val, and when he said at the outset that he does not want to call PhilHealth as the national insurer anymore because it is now the national purchaser. So I want to ask now, so why did you do a study on coverage, on insurance coverage if you're now saying that PhilHealth is not? No, but I do agree with Dr. Val that we are at a particular point in history where the Philippine Health Insurance Corporation is starting to have, shall I say, a paradigm shift. You can be positive by calling it a paradigm shift, or you can also say identity crisis. Why identity crisis? Because PhilHealth was born out of Medicare in the 1960s, and Medicare was not really thinking about primary healthcare at the time. Primary healthcare only was articulated in 1978, Alma Ata. Medicare predates primary healthcare insofar as the years are concerned. So now that RA 7875 and most recently RA 11223, the UHC law, suddenly told PhilHealth, hey guys, you have to start buying primary care services. So Val is right. Dr. Val is right. We are now moving from a totally insuring or insurer role to now being a strategic purchaser. And a strategic purchaser needs granularity. We need to zoom in. I already mentioned the utility of having a map. I would imagine that this map, you can zoom in, zoom out. Ideally, although Val will tell me, stop asking for more granular levels because you're going to start having data problems. Of course, understandable. But as close as possible, rather, to the locus of action, which would be your province-wide health system, and in the case of highly urbanized areas, the city-wide health system. Now, when it comes to data, so Dr. Val also said, and I quote, we assembled this data over months and months. I could feel the angst. I could hear the anguish. Months and months, sabi ni Val. No? So, ang tagal. It takes some time to assemble data from the various sources, and just a very commendable effort, therefore, for all the co-authors. But you know what? As we in policy would say, we needed that data yesterday. As much as possible, we would want real time, but that's always a challenge ever since. For monitoring and evaluation, the policymaker, the implementation agent needs as real time as possible. And then you have a very well-meaning technical assistance partner like a PIDS trying to run after the deadline. But what can we do, or what can you do rather, when the data has to be assembled? So it actually drives home to the point in the first recommendation of Dr. Val to enhance not just the use of data, but even the shall I say, the cleaning, the quality control, the assembly of data, so that policy and operations can indeed be informed by the what did Val call it? A million data points. Yeah, and if there are code cards for the social media team, that's a very nice one. No? A million data points to help us achieve our million dreams when it comes to universal healthcare for the millions of Filipinos out there. Now, having said that, so what does it mean to be covered? Val pointed out that insofar as direct contributors are concerned, there is an inverse relationship between population coverage and poverty incidence. Dr. Val doesn't have to answer it right now, but I'm curious if this inverse relationship was actually based on the direct contributors. Because in theory, if everyone is covered and indirect contributors are paid for, at least I would think there should be no inverse relationship. But if the way I understand it, if it's based on data specific to direct contributors, then my question becomes, nasan na yung bayanihan? Where is the social solidarity? Because if indeed the poorer you are, then shall I say, the less covered you are. Is that correct? The more that you contribute, then therefore, tama ba? Inverse. So the more covered you are, the less poor you are. So it doesn't sound like a social solidarity, because the way that this was designed or that we are supposed to be operating is we should be giving more resources, at least to those who need it more. Then again, direct contributors like myself are the ones who will also say, so what's in it for us? Ang laki-laki ng kaltas sa payslip nitong PhilHealth na to. I mean, I may be a PhilHealth official, but I also pay premiums. And when I look at my payslip, what's happening here? And I feel the pressure to deliver. And when it comes to delivering, Dr. Val mentioned the number of beds. And he had this nice graph that mentioned, I was looking at the map, there seemed to be a green spot somewhere over Baguio, somewhere in the Cordilleras. Makes me wonder now, is it because we're building hospitals where they're not needed? I'm not saying that the Cordillerans don't need hospitals, but I think this is something worth investigating. Is our health facility enhancement program actually building beds where it is needed, where the beds are needed? Because if you have the data telling us that in a mountainous area, the bed to population ratio is high, maybe because there's not enough people there, but there are just so many hospitals there or so many beds. And then if you look at the very dense areas, obviously like Metro Manila, Cebu, and Davao in the map that Val and colleagues have generated, the heat map shows that the number of beds per population is just so low. So now it comes into, what comes to mind therefore is the latest executive order on the health facility development plan, which I understand is trying to rationalize when, where, and how the DOH and its partners should build health facilities. It's no longer about just building left and right, but it's about targeting. And I think the spatial analysis, spatial hindi yung special na spatial, but spatial because of a space that Val and colleagues did, is really going to help implement this HFDP. Now let's talk about the admission rates that Val and colleagues presented. I really agree that there is a big question on why there are higher admission rates among the poor. But then again, the data set here is PhilHealth, right? Maybe, this is my hypothesis, maybe it's because local governments rely more on PhilHealth compared to private hospitals. Of course, the PHAP may probably say, no, Dr. Domingo, we also rely on PhilHealth. That's why we're asking you to pay up on your obligations. But if you ask me, local government units, based on my anecdotal experience when going out in the field, they really do rely a lot on PhilHealth. And maybe perhaps the small private hospitals. Large private hospitals probably can survive more than the small ones, but the small ones, and including the LGU hospitals, they rely a lot on PhilHealth. So perhaps the reason why higher admission rates are there in these particular kinds of facilities, it's because they make an effort to really make sure that they are able to claim, and it shows up based on our data set. Now, what about the high admission rates of the formal sector? This is also most useful for discussions when it comes to complementation with HMOs. Everyone keeps on saying the law actually tells us that PhilHealth should start working in complementation with HMOs. But did you know, ladies and gentlemen, everyone, that by default, HMOs actually enforce complementation? In fact, HMOs require that for you to be able to use their benefits, I see Dr. Sierra nodding on the screen, no? Then you must be a PhilHealth member. Because if you're not a PhilHealth member, then the HMO will say, well, pay your PhilHealth premium first. So there's a love-hate relationship therefore because we love the HMOs for making sure that our formal members are actually paid up when it comes to their PhilHealth contributions. But it also brings to mind that the best claimers, the best users of PhilHealth, again, are not the ones that need PhilHealth. No, it's the formal economy who have stable, relatively stable jobs, relatively stable sources of income that are benefiting from PhilHealth. So again, maybe I should stop there because it's raising more policy questions that I need to answer. But now, what about NCD admission rates? I wonder what case rates were used as the basis for these particular graphs. I'm not saying it's wrong. It's actually a very good, what they call this, a heat map and distribution of data. But it will depend on what case rate and therefore what disease entity you're looking at so that we are able to answer, is it something that can be addressed early on in the continuum of care where prevention is actually better than cure? Which brings me to what Dr. Val said, that it's about time for Dr. Albert and the primary care team to improve primary care operations because the ambulatory care sensitive conditions compose around 34%, 33.61% of admissions. We need PhilHealth Consulta. And I think the Department of Finance will support me. I hope you're listening out there, DOF colleagues. This is the reason, maybe this is the reason why that no less than the President of the Philippines in his SONA is actually bannering Consulta. Is actually saying, let's all get registered, let's all use Consulta. Because the higher demand for hospital services might point to the lack of primary health care or primary care infrastructure. Something we need to work on because, as Dr. Val said, we are no longer the health insurance agency, but the health purchaser agency. Paano na yan? Hindi na kami PHIC, PHPC na kami. Philippine Health Purchasing Corporation. But let's see. Now, what about effective coverage? Dr. Val and colleagues pointed out that quite a lot of a high proportion on average, again, here we go, on average of the hospital bill is paid for 60% by PhilHealth. But remember that case rates are fixed. So this is more of my amateur economist question for Dr. Val and the economists here on screen or in this particular webinar. Since the case rates are fixed and we see variations in the proportion of support value, does that mean that we're actually capturing the price variability of services? Whereby the support value in NCR is very low. I think it's the lowest in GMA, no? Not Gloria Macapagal-Arroyo, but the greater metropolitan Manila area. It's very low in GMA, probably because the hospitals here are charging more than similar high-quality hospitals in the Visayas. I mean, hats off to the Cebu Institute of Medicine. Friendly competition with the UP College of Medicine where I come from. But CIM, we have a high respect for them because their quality is also very high. But if we are to believe the data that the spatial data that Dr. Val and team actually pointed out, why is it that in the Visayas, support value is higher, but in the Metro Manila area, it's actually lower. And I see the moderator nudging me now and saying, time to wrap up, Dr. Domingo. So actually, I'm at the last part of my reaction, and I do agree with the recommendations. I already mentioned enhancement of data, but the one
You
that
still have 2 minutes. You still have 2 minutes.
Oh, I'm still on time. Thank you.
That's
So
fine. You may finish, sir.
right.
It's
So
fine.
the supply challenges, no, we need to address the supply challenges. Yesterday, I was at the forum at St. Luke's. I was with the rehabilitation specialists and they were asking PhilHealth to pay for rehabilitation services. I asked them, so how many physiatrists, how many rehab med doctors are there in the Philippines? And they said 400. And I said, even if PhilHealth designed, assuming that it will, a benefit package that will pay, are there enough physiatrists out there? Meaning supply side challenges. Of course, they will point back to us and they will say, well, because you're not paying for it, the physiatrists are going elsewhere abroad because there is no market for their services. And then it becomes a chicken versus the egg. No, which should come first? PhilHealth or the supply side? Demand side or the supply side? The never-ending question between PhilHealth and the DOH when it comes to the prioritization. Which brings us finally to the last 2 points of Dr. Val, which I fully agree with. Number one, we need to boost primary health healthcare or primary care in our particular terms, because we don't cover health promotion. We cover the services, primary care services, because we need to bring down hospital costs. We need to bring down hospital admissions. It really is true that an ounce of prevention is better than a pound of cure. And to the last recommendation of Dr. Val, that strategic purchasing has to bring down out-of-pocket expenses, that's precisely the point, which is why, selling my own particular line of work, we need to really improve primary care in the Philippines. Over back to you, Dr. Sheila.
And thank you very much, Dr. Albert Domingo of PhilHealth. Thank you for those insightful comments on the findings and recommendations of the study of Dr. Val and his team. Just as thought-provoking is the study of Dr. Val and team, your comments and your comments are also very, on point. Thank you very much for your candor. And if you have questions for Dr. Albert, I heard he is leaving at 4 o'clock. Please type them on our Q&A box so he can read it. And I think we still have ample time for the open forum before Dr. Domingo leaves our forum. Okay, so at this point, we will now go to our next discussant, and this time we will hear from a policymaker, from a lawmaker, and we are very honored that we receive the reactions of the chairperson of the House Committee on Health I'm talking, and he is Honorable Sir Jacob B. Gatto Jr. So we will hear the comments of Congressman Gatto, who is a physician and a politician, currently serving as representative of the Lone Legislative District of Batanes. A native of Batanes, Congressman Gatto was born in Sabtang but grew up in Itbayan, where he completed his elementary and high school education. He graduated from the University of the Philippines College of Medicine and became an ENT specialist. Well, as I've mentioned earlier, he currently chairs the House Committee on Health, and he recently lauded the signing into law of the Regional Specialty Centers Act as a decisive leap to ensure accessibility of health facilities across the continuum of care in the country. So Congressman Gatto cannot join us in person today, but he sent us his video. And at this point, may I request our webinar team to play the video, please?
Distinguished guests, esteemed colleagues, and fellow advocates for health equity. It is with great pleasure to speak before you today on this very important event, organized by the Philippine Institute for Developmental Studies. I congratulate the authors of the study titled Spatio-Temporal Analysis of Health Service Coverage in the Philippines. Clarissa Joy A. Flaminiano, Vicente Alberto R. Puyat, Victor Andrew A. Antonio, Jana Uy, and Valerie Gilbert T. Ulep for undertaking such important research on the Philippine health system, which highlighted the disparities in 4 aspects of health service coverage: population coverage, facility coverage, service coverage, and financial protection across different subpopulations. As chairperson of the Committee on Health of the House of Representatives, I welcome the study with great enthusiasm, and I'm very eager to learn from the ensuing discussions on the subject with the end view of determining possible reforms or measures that would further promote and strengthen universal health care in the Philippines. With the enactment of Republic Act No. 11223, otherwise known as the Universal Health Care Act or UHC, One of our major goals is to ensure that Filipinos have access to quality, affordable, and accessible healthcare services without suffering financial and economic hardship. Achieving universal healthcare in the Philippines is no easy feat. To address disparities in health service coverage, it is essential to strengthen the health financing program through the Philippine Health Insurance Corporation, or PhilHealth, which is the primary purchaser of health care services. This strengthening means ensuring that PhilHealth can provide comprehensive coverage to all Filipinos, investing in primary care services to ensure that Filipinos have access to preventive and promotive care, and investing in financial protection mechanisms to ensure that Filipinos are not impoverished by the cost of healthcare. Now, please let me briefly apprise you of pertinent bills referred to the House Committee on Health in relation to the four aspects mentioned in the study. On population coverage, although the UHC provides that every Filipino citizen shall automatically be included into the National Health Insurance Program, translating to 100% coverage of all Filipinos, the researchers based their study on registered beneficiaries and their dependents. The study mentioned that the urban-rural disparity in membership coverage is concerning, and there is a need to improve membership coverage to ensure equitable distribution of benefits to all Filipinos across provinces. Under the Committee on Health, we have slated bills on PhilHealth reforms on the coverage of paying and non-paying members to ensure that all members have access to health services. These bills also include amendments on the original law regarding on premium rates members to pay. On facility coverage, not all Filipinos have access to health facilities that can provide services they need. In geographically isolated and disadvantaged areas, or GIDAs, there are not enough health facilities to meet the needs of the population. The study discussed disparities on hospital bed density across regions and provinces, which reflect clear discrepancies on the accessibility and utilization of health services, with wide variability in hospital bed density across provinces. The committee has pending meetings on bills regarding health facilities, such as House Bill on Health Facilities and Services Regulations, which aims to modernize the regulation of health facilities and services. On service coverage, not all Filipinos have access to the full range of health services they need. For example, many Filipinos do not have access to preventive care services. The research showed large disparities between LGUs in terms of available human resource for health, facilities, and funds for providing primary care. Barriers in the availability, accessibility, and affordability of services must be addressed to ensure that target populations are being covered by essential health services. The study further reaffirmed that government facility and service augmentation projects are not always allocated based on the poverty incidence of provinces and municipalities. The Committee on Health has pending bills relating to improving the service coverage of healthcare services, such as the DOH Hospital Bed Capacity and Service Capability Rationalization Act, which will grant the DOH the authority to automatically increase bed capacity and service capability of DOH hospitals without needing legislation every single time. This bill would improve service and facility coverage of hospitals as it would open for more patients to be treated. On financial protection, even when Filipinos have access to health services, they may still face financial hardship due to the high cost of care and services. The study mentioned that the NHIP does not cover more than 40% of charges for hospital services, suggesting that the out-of-pocket and other sources of expenditure are required to pay for hospital charges. The results also suggested that large variation in support value across diseases necessitates a strategic shift in the purchasing of services and reassessment of revenue generation functions to ensure that there are enough funds to reimburse all diseases that PhilHealth offers benefit packages for. Congress has bills on expanding PhilHealth package benefits to cover more out-of-pocket expenses. House Bills 8470 and 8884 would expand PhilHealth coverage to include a benefit package for all mental health disorders, and House Bill 3405 mandating PhilHealth to develop a comprehensive dialysis benefit package. These bills have an end goal of covering more charges to make treatments and services more accessible to the Filipino people. We agree that effective financial protection in the health system should reduce out-of-pocket patient costs that are not covered by insurance, as mentioned in the research. These challenges are compounded by the fact that the Philippines is a country with a wide range of subpopulations, each with its own unique needs. For example, the needs of rural Filipinos are different from the needs of urban Filipinos. The study said that there may be differences across different subpopulations in terms of awareness or knowledge of the health services offered within their area. There are also bills and resolutions in the committee that aim to bridge the information and knowledge gap among the different subpopulations. House Resolution 803 urges PhilHealth to conduct information drives and strengthen awareness of Consulta package, which helps aid the citizens' need for outpatient services. We have come a long way in terms of implementing the Universal Healthcare Act. However, there's still much to do and improve to ensure that health service coverage in the Philippines is indeed a universal and equitable. We must address the obstacles and significant disparities in coverage across different subpopulations. By addressing these challenges, we can ensure that all Filipinos have access to the quality, affordable, and accessible healthcare services they need. Please be assured that the House of Representatives and its Health Committee are working towards realizing that the universal health care by enacting legislation that will address the specific challenges to health service coverage in the Philippines. Legislative intervention also includes exercising Congress oversight function to ensure that it is effectively holding the executive branch accountable for its commitments to universal health care. In addition to legislative intervention, evidence-based studies such as this PIDS study will contribute to realizing the universal health care. These studies can help us to better understand the challenges achieving universal health care and to identify effective solutions. Please be assured that your policy recommendation will not fall on deaf ears and will be taken into consideration in the course of legislation. I would also like to extend an invitation to the Philippine Institute for Development Studies and the authors of the study titled Spatio-Temporal Analysis of Health Service Coverage in the Philippines once the session in Congress resumes. We would be honored to have you as resource persons to discuss your findings regarding pressing health concerns. Let us work together to realize the Filipino people's right to health. Mabuhay tayong lahat. Thank you very much.
Thank you very much, Congressman Siriaco Gato, the chairperson of the House Committee on Health. We greatly appreciate your pricing us on the on what Congress is doing, the pieces of legislation that you've mentioned to address inequities in health service delivery, to ensure that health service is delivered to all Filipinos, leaving no one behind. Okay, so at this point, we will now have our third and last discussant, and we are very honored to have with us today the president of the Philippine Alliance of Patient Organizations, or PAPO. Let us all welcome Ms. Karen Villanueva. Ms. Karen Alparce Villanueva is currently, as I've said, the president of PAPO, or the Philippine Alliance of Patient Organizations, and she is also the founder of Rare Cancers Philippines. She has over 30 years of experience in the private sector, specializing in communications and policy work, where she has spent the last 20 years in the healthcare industry. She also served in government as board member of the Philippine Health Insurance Corporation and as consultant for the health promotions and communication services of the Department of Health. She was previously External Affairs Director of MSD and was also Corporate Affairs Director of Pfizer Philippines, where she was instrumental in the inception of PAPO. She's also chairperson of the International Public Relations Association Philippines chapter and a member of the Filipino Women's Network. Ms. Villanueva, ma'am, the floor is now yours.
Thank you so much, Dr. Sheila, and good afternoon po. I must admit, when I got the invitation, I had to Google spatio-temporal because I didn't know what it meant. So I'm glad that I listened to the discussion, and simply put, this study aims to look at a more comprehensive, overarching, and as what Doc Val said, a more granular analysis, which hopefully can provide us better insights, a more targeted approach, and hopefully address gaps in health equity. So thank you to the team of the Philippine Institute for Development Studies for inviting PAPO to share its perspectives on this timely issue of probing healthcare inequities. As the government rolls out primary healthcare as the main vehicle to implement universal healthcare, it is critical to determine population and facility coverage, service coverage, and financial risk protection, which are the key metrics to measure UHC. Harnessing digital technology and ensuring an information system that provides real-time data will make the process less painful and tedious, and hopefully we can have more studies of this sort. So before I give my reaction, allow me to just tell you a bit about the group I represent. Not many people know that the Philippine Alliance of Patient Organizations exists. We're actually an umbrella organization of 52 disease-specific groups. So anywhere from HIV/AIDS to infectious and diseases like cancer and rare diseases. Our mission is really to help build a people-centered health system in the country. And we want to be the unifying voice of patients. And our three focus areas are actually advocating for patient rights, universal health coverage, and patient participation in policymaking. So we're very thankful for all the opportunities where we're able to participate. So nationally, PAPO sits in various technical working groups, councils, and coalitions. And really, the role of patient organizations is essential to understand the needs and expectations, as well as represent the views of their communities on access to health issues. We work with diverse communities of patients to get our voices heard by all involved in healthcare. So that's why it's important to engage patients, involving them in an active, collaborative, and non-token way, where decision-making is guided by patients' contributions as partners, recognizing our unique experiences, values, and expertise. So by way of my reaction to this study, where gaps were already identified, and we heard Dr. Albert and Congressman Gatto talk about what they see are the areas of solutions, let me just add another key policy area for consideration, and where specifically patient groups can make a difference and be part of the solution. So the study shows access and utilization inequities, which are linked to socioeconomic factors such as income, access to information, and other factors. In addition, widespread NCD and ambulatory care sensitive conditions, high admission rates, show the lack of preventive, and I would posit, poor health literacy. So health literacy is simply the ability to understand health information and, more importantly, navigate the health system. So improving health literacy is critically important in tackling health inequities. People with low health literacy have poorer health status, higher rates of hospital admission, and are less likely to adhere to prescribed treatments and care plans. They also experience more drug and treatment errors and make less use of preventive services. The next area of possible collaboration and solution is information and communication. Patient involvement in conceptualizing information can improve its relevance, clarity, and context. Patients can provide insights on local customs and beliefs, health literacy, and healthcare structures. Developing lay-friendly information materials, communicating regularly on new benefits. As mentioned by Congressman Gatto, there are several bills seeking to improve access to information, policies, and processes. It's also worth considering increasing the use of peer education and encouraging patients to take an active role in managing their own health. In other words, patients need to be active participants and not just passive recipients of care. Very important also is training families to deliver care, especially in responding to patient needs in a home care environment, should also be considered. So just as a final comment, because this is very close to my heart, cancer is very close to my heart, I looked at the list of diseases and its support value, and I just want to understand the data and the support value for cancer, which is already in the top 3 causes of death and disease in our country, as well as the support value for rare diseases. Because we believe that under universal healthcare, no one should be left behind. So I'll stop here and thank everyone for your attention. And if you have any questions, feel free to post them in the chat box. Thank you very much.
And thank you very much, Ms. Karen Villanueva of PAPO. Well, we will hear more from Ms. Karen during the Q&A. So if you have questions for her, just type them in our Q&A box. Thank you very much, ma'am, for highlighting the importance of improving or enhancing health literacy, so as to, help help the population, help Filipinos become more active participants, more active caretakers of their own health, because that's very important for us. We shouldn't just rely on the government. We shouldn't just rely on the private sector, because at the end of the day, we should be active participants of our own well-being. So thank you very much, Ma'am Karen. And at this point, before we go to the open forum, let's have a poll. Let's engage our participants by having a pop quiz. And team, okay, so here is our pop quiz. And as we have heard the recommendations of Dr. Ulep, Dr. Albert, Congressman Gato, and also Ms. Karen Villanueva, and we want to hear from you what you think is the most critical factor to improve healthcare accessibility and service coverage in the Philippines. Okay, is it A, capacitating LGUs and healthcare professionals? B, expanding breadth, depth, and accessibility of primary care services. C, enhancing administrative processes for membership enrollment in health insurance. Or D, harmonizing initiatives of agencies and organizations for better service coverage. We know that all four factors are important, but in your viewpoint, which for you is the most critical? We want to hear from you, okay? So is it A, B, C, or D? Okay, I think medyo mahaba yung ating question and also yung ating mga options. So let us give our participants or our respondents time to process them. Okay. Well, are the results ready, team? Let us look at the results. Okay, and while we are waiting for the results, well, if you have questions, as I've said, just type them on our Q&A box. Okay, so, okay, majority of our respondents answered letter B, which is expanding breadth, depth, and accessibility of primary care services. Okay, and a while ago, during the Dr. Albert's presentation, he gave us the context of PhilHealth, right, Dr. Albert, that when, you know, the precursor of PhilHealth was Medicare, and that time primary health care was not included, but over time it became it was apparent that it's really very essential, and in fact it was highlighted as a very critical factor in ensuring health in our universal health care act. Okay, so there you go. Thank you very much for your participation in our pop quiz. And at this point, may I give the floor, before we go to the questions, may I give the floor to Dr. Val Ulep for his reactions to the, if you have anything to say, if you have any response that you would like to say, please do. And I think we will also be joined by his co-author, Mr. Victor Antonio. In fact, Mr. Antonio has responded to some of the questions in the Q&A box. Okay, go ahead, Dr. Ulep.
So thank you, Ma'am Sheila. So I would like to thank again to our discussants for their thought-provoking insights. So I'll start with Dr. Albert. So Dr. Albert and I always have this like healthy arguments on many things, but one thing yung parehas kami, which is pushing for primary healthcare. No? So I think he raised a very good point on why I don't want to call PhilHealth as an insurer, and why are we still doing estimates on coverage. I agree with you. I think I said that idea that we shouldn't be calling PhilHealth as an insurer because there is this clash in value system in many of the narratives from our policymakers that because PhilHealth is insurer, we shouldn't be insuring primary care because it's not, because it's predictable, right? But when we shift that paradigm that, okay, PhilHealth is now a purchaser, you can now purchase a comprehensive healthcare services. So that's dun ako nanggagaling why we shouldn't be looking at this old paradigm of, covering only those services that are unpredictable, right? So yun, we should be shifting that paradigm. No? I think another important question na raised ni Albert is the differences in support value could be a reflection of the different prices across areas, right? And that is very true, right? Because in the Philippines, we are operating in a market-driven healthcare system, right? So a doctor in Manila could just charge 1 million, while in Cebu could just charge 10 pesos, right? Because we are the only country without fee schedule, right? There is no way for us to determine the salary of physicians, right? And I think that's one of the reforms that needs another forum. But I think we should start thinking about these critical policies, right? Again, we are the only country without that kind of policy. So it's not just one issue related to PhilHealth, but there are multiple policies that actually affects all these things, right? So and it's one of the areas that's hard to change, right? So but Albert is right. It's because even if PhilHealth is constantly increasing the numerator, but hindi naman nila ginawa yun in the last 10 years, your denominator, which is yung denominator ng support value, will always increase, right? Because you don't have that ability to control the denominator, right? So, there are policies like that we need further discussion, right? And there are policies that we need to actually embrace na medyo mahirap, but we need to as we move forward, as we mature as a health system, right? In countries like Malaysia, for example, or Thailand, they know how much they pay for physicians. They know how much they pay for a drug, because that's in their regulation. But we don't have those things, right? So you expect that the denominator will always increase, no? So I hope we can have a separate discussion that Dr. Albert. The second one is for Representative Gato. I always I applaud him for highlighting the importance of primary care and the importance of evidence-based decision making. We are always present at the IDS to help you with important legislation, no? And for Ms. Karen, so laging partner natin yan si Ms. Karen. So I totally agree with you that in many decision points, we need to engage patients. They need to have a voice sa table, no? When it comes to development of benefits, for example, when it comes to expanding financial protection, etc. Patients should be at the center, no? And I agree with her on her points, no? And I think she asked the questions, bakit walang support value yung cancer? And this is also related to the question of Albert. If you look at the PhilHealth data, they have ICD. So we use ICD to track whether a particular claim is NCD or infectious disease. So we have that. So to answer Ms. Karen's question, yes, we can calculate cancer. I think hindi lang namin nalagay, but we can calculate it for you. Kahit anong type of cancer we can, because the ICD-10 code allows us to identify whether this cancer is lungs or liver, etc. So we should have that po. But I think wala lang po dito sa presentation. But we can see the variation in support value for cancer across level of hospitals, public, private, across provinces, etc. That should be possible because of the data set. No? So I think yun lang po yung sasabihin ko. But I'm gonna give the floor to Albert. Baka may counter ano siya.
This is a healthy discussion, as you mentioned. So, Dr. Albert, Dr. Domingo, would you have anything to say, sir?
Yeah, I only wish that Dr. Val invited someone from DOH, like maybe Assistant Secretary Ho or another DOH son.
We did, actually.
But seriously, the context notwithstanding, As Dr. Ulep correctly pointed out, this is a whole, we love saying these terms, whole of system, whole of government, whole of society. Well, there are so many holes that we need to actually fill. And when I say hole without a W, mga butas sa ating sistema na kailangang ayusin. And these different holes cannot just be addressed by having another framework of a whole of society. We have to address the implementation issues now. We made the law 2019 Universal Healthcare Act. It was, yeah, sure, it was sidetracked. Actually, I don't think that the pandemic sidetracked it. I think the pandemic highlighted particular areas that need to be prioritized. And just recently, 2 days ago, the president of the Philippines is now is willing to sign off on this executive order that will have the UHC coordinating council. Now, if you ask me, that's well and good, and it's actually shall I say, a mirror of the realities on the ground. We've been trying to implement these things. And by way of having the floor right now, I saw one of the questions. So what's the plan when it comes to primary healthcare or primary care? How are we going to, and thank you for voting for yours. No, not for me, but for primary care. Natitignan ko, sabi ko, 20% response rate out of 169 Zoom participants. I can't say in the majority of participants, but I'm sure out of those who responded, who actually chose letter B, how do we put this into operation? Well, we are already considering increasing, and when I say considering, you know that the number of approvals needed, but we are starting, and maybe Papo can help us. Maybe the participants here listening and watching can help us. We want to increase the capitation rate for consulta. I had to say that slowly so that I will be quoted by media. No, we are in the process of doing the costing because we acknowledge that it's not enough. The 500 and 750, 500 for public, 750 for private, it's not enough to actually attract more providers. We talk of support value, but that's in hospitals. No, I'm sure Val will tell me, Albert, stop asking about primary care. That's beyond the scope of our data. But precisely the point. I mean, the recommendations of Dr. Val is we need to go into primary care now. And so I just wanted to put that out there. Yes, we are considering increasing the capitation rate for consulta without adding additional services for now, so that there will be more room to build markets to crowd in, yung ba in terms sa economics, to crowd in more providers to bring them on board. Thank you.
Thank you very much, Dr. Albert. So that was one of the questions on our Q&A box by Ms. Sheila May Almasa of Minda. But let me jump to another important topic, which is preventive care, no? Because it is seldom talked about in health services, delivery of health services. But it's very important because if your preventive care is strong, then there's less need for, less need to go to hospitals, less need to go to your clinics. And I wonder if preventive care is really being addressed, it's really being promoted in our health system. Any thoughts or any update from our speakers? Preventive care. This has been one of the things also that was emphasized by Ms. Susan Pineda Mercado in one of the fora that we had at PIDS. Dr. Val, and perhaps we can go to Ma'am Karen.
Okay, I'll go first, then siguro si Ms. Karen, then si Doc Albert, no?
Yes.
So if you look at the functions, there are elements of prevention na under consulta ng PhilHealth.
Okay.
But primarily, it's actually a function of the local governments, no? So as a devolved health system, magkakaiba yun. May LGUs na merong preventive care, merong hindi, merong ano. So may variation din in terms of how it's implemented sa baba, no? So yun yung problema natin. May variation in terms of implementation. But I think more than this variation, kailangan din natin i-emphasize yung narrative na bakit hindi nag-invest yung mga decision makers natin ng primary care. No? In many countries, they've seen, I mean, if you look at the political economy of many health systems, ganun din sila dati, ayaw nila na nag-invest sa primary care. But eventually, when they realized that Okay, example, Ukraine, no? So, yung health system ng Ukraine is, ang dami lang ginagastos kasi hospital lang yung binibuild nila. So, every year, increase yung health system nila before the war. It's because walang primary care. And yun yung issue natin, no? Even we keep building specialty hospitals na wala naman nagka-catch, you will expect escalation of cost, right? So I think we need to change that paradigm, no? Na it needs to have strong primary care to protect the hospital. So, but again, it's not politically palatable, but we need to show the numbers that it makes sense, no? From a fiscal perspective, I hope some people from DOF and DBM would appreciate that, no? Na it's not only a health issue, but it's actually a cost containment issue when you think about it in the medium to long term. But maybe Doc Albert and Ms. Karen could provide more insights on preventive care.
Yes, Ms. Karen, please.
Yeah, so I totally agree, no? Preventive care is the best way to address the increasing cost of hospital care. But there's so much barriers, even from the patient side, right? One is, as I mentioned already, yung health literacy and patient navigation, no? So my challenge, simpleng ubo at sipon, pupunta na agad sa pulmonologist. So may ganung attitude, hindi ba? Tapos may attitude na mas magaling ang mga doktor sa ospital. So mas gusto nilang pumunta sa ospital kaysa sa health center, no? So may ganung challenges. And also, I think now, no, in terms of yung rollout ng konsulta, may problema not just on the demand side, which is patients actually registering to consulta, but also the supply side, yung primary healthcare provider network, no? Takot yung private in our country where majority of care is provided by the private sector, takot sila to buy into the network provider, no? So may mga ganong challenges. And I think also in terms of getting the whole package, no? And I mean from diagnostics to medications. Kasi if you don't provide that whole package, patients will not want to go to the healthcare provider. Kasi malalaman nila may sakit sila, but what do they do after? So you really have to provide that. And then also yung pasyente mismo, no? Nandiyan na yung medications, nandiyan naman yung services, pero matigas ang ulo. Maraming affected by social media, all the information, all the news out there. So maraming factors, but I absolutely agree, no? That primary healthcare is the way to go. But how do you also shift, our medical students to want to be primary healthcare? No? So that's my view. Thanks.
So it's an issue of trust. It's also an issue of literacy, an issue also of accessibility, and a whole lot of factors. Dr. Albert, your turn, sir.
Yeah, I think it's an issue of politics.
Okay. Issue of politics.
O di ba? Talagang yun talaga yung pasok eh. It's an issue of politics. But Dr. CR, as a practitioner of public policy, and before everyone starts quoting me and putting me on media and saying there's a PhilHealth person saying it's all political, because it is political. Politics is not necessarily bad, no? The reason why hospitals are so popular and politicians want to build more hospitals, it's because they see the response in terms of votes. However, the DOH now has a very interesting messaging. The first priority out of the 8 priority action agenda items of Secretary Herbosa in Tagalog is bawat Pilipino ramdam ang kalusugan. Is that not a political statement? And I think it is a very strong political statement. Dati po kasi ang PhilHealth mararamdaman mo lang kapag nagkasakit ka. Yun yung sinasabi ni Dr. Valle, insurer. You have to fall ill before you actually feel that you are covered by PhilHealth. Aba ngayon, mga kababayan, hindi mo na kailangan magkasakit. Magparehistro ka sa konsulta, mararamdaman mo yung PhilHealth. mararamdaman mo hindi madaling magrehistro. I mean, we're trying to fix that. No, but I cracked that joke specifically, and I'm like shooting myself in the foot because it's my job, it's our team's job, it's PhilHealth's job to make sure it is easy, madali dapat para sa bawat Pilipino na maramdaman ang kalusugan. Kaya nga tataasan na namin yung capitation rate. I respectfully disagree na natatakot yung private sector. Hindi sila natatakot, matapang sila. I can cite 2 or 3 companies who are already going into primary care. In fact, sila yung kausap namin at nagsasabing, taasan nyo na yung capitation rate ninyo. Hindi sila natatakot, hindi sila convinced. Kasi ang baba ng capitation rate eh. So there are a lot of things going on here, and I will cut my intervention short so that we can talk about other things. But number one is the political economy and the incentives have to be all aligned. Over.
Thank you very much, Dr. Domingo. And may we also hear from a co-author of Dr. ULEP, Mr. Victor Antonio. Mr. Antonio, Victor, would you have anything to add?
Yeah, thank you so much for having me on. Hi, Val. So from my perspective, right, as one of the people who actually delved into the back end side of things, we work behind the scenes to go through that that 80 to 90% work that Val mentioned, and he was very emphatic about that. And there's a reason for that. It's really because from a perspective of trying to gain information and insight and trying to actually enact policies based on evidence and based on data, what we wanted to do is to ensure that different agencies having provided different data sets actually can communicate with one another. So not just on a policy perspective, but also on the behind the scenes, under the hood data perspective. And that's one of the issues that we encountered at the beginning. So even though we had this sort of idea of what we wanted to highlight or what we wanted to answer in terms of problems to solve and things of that nature, the geospatial aspects, the temporal aspects had to be consolidated and married in some way. So for example, the data from PhilHealth had to be consolidated with the data from DOH, that had to be consolidated with the data from PSA, which had to be married with the data from international standard data sets. So those are things that we had to merge together. So I think moving forward, one lesson, and again, I'm speaking from the point of view of how to get to the policies, right? And at the end of the day, from a data science perspective, what we want to do is to provide impact and to provide solutions to the problem at hand. And if we want to get to evidence-based policy making, which is one of the things that was emphasized earlier, there's another aspect of that, which is engineering and making sure that the data will be ready to actually support in that, right? So for us, for example, one of the things that were highlighted was the heat map earlier. So for us to get to the heat map, which involves a lot of components under the hood, we need to make sure that there are things that when we want to enact a policy, there's actually a lot of things happening behind the scenes. It's something that we have to accept and recognize so that we can get into the right insights and the accurate and precise solutions. So again, I'm just attacking that from that perspective as well, building on what the previous speakers have already said. Thank you guys for giving me this opportunity.
Thank you, Mr. Victor Antonio, for emphasizing the importance of proper data management. This is very important because we're talking about evidence-based policy making, evidence-based program implementation, program planning. Okay, so let me jump to another important topic, which is digitalization, no? So, okay. Okay, nakikita ko yung reaction ni Dr. Albert, Dr. Domingo. How can we leverage digitalization, no, to address these issues? And are we using it enough? Or may kulang ba? And yun na lang muna. I won't go to, other issues about data, digitalization. But yes, that basic question on how can we leverage digitalization, and would you have specific recommendations on how to use it to address this gaps in facilities, in service coverage, population coverage, etc.? Okay, who would like to take the first crack? Okay.
I'll go first because I want to challenge Albert on this. No,
Sure.
no, because of digitalization. So number one, remember if we are shifting PhilHealth to be a purchaser, di ba pag bumibili ka ng gamit, alam mo kung ano yung binibili mo. Like, oh, maganda tong quality na tela, etc. But without information on the quality of services na binibili mo sa doktor, you cannot be a good purchaser, right? So, and that's the reason why data is very important, because that's the only way na malalaman mo that you are actually buying the services that you need to, right? So without data, walang primary care. It will never happen. So first point. The second point is, but when you talk to hospital, it's actually expensive. No, it's actually, there is a cost associated with it. No, and in many countries, it's part of the capitation, right? Yung cost ng EMR is actually folded into the capitation. So the point is, we need to pay for it as a purchaser, right? For example, in CMS in the US, they actually pay the provider so that they can submit high quality data, right? So the point is, I think yung ginagawa natin for many years is just legislating, oh, we need to submit, asking providers to submit their data. It doesn't work. We need a more proactive way of getting data, which is to actually pay for the data. I mean, not in a direct way, but there is an incentive. We need to put incentives so that providers could actually give that information. So both legislation and actually thinking about how to cover the costs, because yun yung main problem. So I think yun lang yung gusto kong sabihin, but as I've said, without data, you cannot be a good purchaser. So yun. Albert, over here. Perhaps si Victor then could provide maybe a broad understanding on how it should be done. No, when digitalization.
I have to step in because I have to leave very soon. So let me just respond. No?
Sadly,
Sorry for
Dr.
that.
Domingo.
Kasi baka humirap pa yung mga tanong ni Val, kaya tatakas na ako. Joke lang. No, I mean, I'd have no contentions. I have no debate with Val on his second point. That's why tataasan na nga yung capitation rate, Val. Ano ba? Huwag mo nang pigilan.
Okay.
Capitation rate. Number one. Number two, quality measures. Quality measures. Tama, kailangan mong malaman yung kalidad ng gusto mong bilhin. Ang tanong sa healthcare, at alam to ni Dr. Val, paano ko susukatin? Pagandahan ng clinic, pabanguhan ng palamigan ng aircon, pagandahan ng grand piano. I mean, no, I crack those jokes kasi parang there seems to be a misunderstanding. Yesterday, again, I was in the forum, I was with rehabilitation specialists. Sabi ko, kasi they asked a very specific question. Pardon me if I mention names, but it was an actual discussion. They were asking about the rehabilitation services at Quirino Medical Center compared to St. Luke's BGC. Sabi ko sa kanila, alam nyo, it's difficult kasi to compare, for example, Philippine Airlines with Cebu Pacific. Because Philippine Airlines is a full-service airline, Cebu Pacific is a low-cost airline. Magkaibang market yan eh. In the same way that St. Luke's caters to a different market, and so does Quirino Memorial Medical Center, it caters to a different market. But maybe the question should not be on the amenities. When we talk about airplanes, that's why binanggit ko yung PAL saka yung SEBPA. We want to find out if the plane will take off, fly, and land, and deliver you safely to your destination. And I think that is the quality. And going back to the healthcare analogy, I don't know at this point, or maybe I have some ideas which I can discuss in a very long webinar different from this one. But the thing is, we are not yet that sold. Kasi right now, puro inputs yung mini-measure. Alam ni Doc Val to eh, di ba? Frustration ka rin yan, Val. Wala tayong debate. You have an advocate inside PhilHealth. I am not so convinced that when you measure the size of a particular primary care room, on the measurement, on the number of bottles of reagents you have, it's not going to translate on whether you're giving quality care or not. I'm more interested if the doctor, the nurse, or the midwife is asking the right questions, doing the correct diagnosis, and delivering the right treatment for a particular patient. But I think this is my last point because I have to go really soon. How do you measure that? And maybe that is my next request, kasi mahilig kami mag-request sa PIDS. PIDS, help us out, please. What's the quality measure for primary care? Yun lang. So, paalam ko na po yun. I'm really sorry to all the viewers because I have another appointment I have to attend to. But thank you so much for inviting PhilHealth and yours truly to this particular webinar.
Sayang, Dr. Albert, but thank you very much, sir, for your presence and for everything that you've shared. And we hope to have you again in our future events. Salamat, Dr.
po.
Albert.
Ingat.
Salamat po. Okay, thank you. So, Ma'am Karen, please.
Yeah, so I totally agree, no? So in Papo we have an action learning project, no, as an output of our AIM course on healthcare leadership management. And one of the ideas for a project is a rating system similar to your TripAdvisor of healthcare providers, facilities. And what kind of metrics are we talking about? They're very simple. That the doctor comes on time, you know, they're treated professionally, they're giving information to the patients, they're charged, fairly. But then again, to the point of Dr. Val, and I totally agree with him with the lack of a fee schedule. That should be in the works. And of course, the accessibility of the doctor to the patients in terms of providing after office care, or after allowing them to get a hold of their cell phone, etc., the quality of their visits when they're confined, etc. So it's been done in other countries, and in fact there's a site in the UK where there's a platform for patients to raise issues in terms of services provided, and the facility or the doctor is able to respond to that particular issue. So there are many opportunities for that, and but we need to start somewhere, and we need to look at the general attitude, the general behavior of patients and doctors, and also at empowering patients on how to talk to their doctors, right? How to communicate, because many times, because of the information asymmetry, we're very intimidated. We get scared and we don't ask the right questions, or just take in information, and when we get home we don't journal. When we get home we forget everything that the doctor tells us because we're overwhelmed with the information.
That's right. Very important points you mentioned about increasing or improving our feedback mechanisms, and also ensuring having a performance-based mechanisms, no, that will allow us to rate, to assess the performance of our hospitals or clinics, and even the doctors, because that's very important to ensure that quality healthcare services are really delivered to the patients, no. And you also mentioned about improving health literacy. Thank you very much, Ma'am Karen. Let me go to which is related to digitalization, yung digital health, no? Because for HMOs, pinapayagan kasi na HMOs usually cover telehealth. And I wonder if this is also done by PhilHealth, kung sinasagot ba yung, let's say, telehealth or mga teleconsultations, no? Because that's one way also of bridging the gap between our doctors, our healthcare providers, and our patients, no? Because yung distance, that's one of the factors, yung proximity ng mga healthcare facilities natin, and through telehealth that gap can be bridged. Would you have any idea kung ano ba to? Is this one of the services being covered by PhilHealth?
As far as I know, we did raise that concern if it's possible to have teleconsultations reimbursed, and they said at the time that there's still no facility for them to be able to do that. But I agree that that's one area that can really help, because as a result of the pandemic, people have already to teleconsultations, and it actually helps also declog
Yes.
right? And in areas which are geographically isolated, that can also offer a lot of potential. So definitely that should be considered, especially with consulta, no? Because it's primary health care.
That's
And,
right.
yeah, yesterday, Papo belongs to a advocacy group called Universal Healthcare Watch. So we're a conglomeration of various advocacy groups pushing universal healthcare. And yesterday, we did a courtesy call to the PhilHealth president, no, Mandy Ledesma, and he talked to us about really improving the registration of PhilHealth members, because we were telling them that they were sharing with us that registration has been slow. And I shared with him that I turned 60 this year and I applied for my SSS and my Pag-ibig retirement benefits online without having to go to these offices. And I said, why can't PhilHealth do that?
Do that. Yes.
Right? Why can't we register our PhilHealth membership online?
Sayang wala na si Dr. Albert.
Yeah, sayang. But the other members of the PhilHealth team were there, and I'm sure that captured in our minutes. So, yun yung ano namin di ba? With everything so possible on your mobile phone.
That's right. Yeah.
You do have something like that.
Yeah, digital tools are, at just on our fingertips, and just waiting to be tapped. So these tools are available to us. So lahat ng tao, halos lahat ng tao meron ng cellular phone, no? Kahit analog, may cellular phone sila. So ang daming possibilities waiting to be tapped, and hopefully through our conversation today, we'll be able to solve those problems, solve these issues, no? And we also have the support, of course, of Congress. A while ago, we have Congressman, we have Representative Gato with us. Okay, so okay, we still have some questions here, and let me read one of those questions, which is from Segundina Devota Dilao. Will the increase of capitation mean now that preventive health care will become expensive just because PhilHealth will cover it? And ready capture payers of premiums for employees will be used to pay for those who cannot pay. Unfortunately, wala na si Dr. Dr. Albert Domingo, but would you have any thoughts, Dr. Ulep? Will the increase of capitation mean now that preventive healthcare will become expensive just because PhilHealth will cover it?
Well, because some aspects of the capitation, when you talk about capitation, it's a payment for the primary healthcare services, and some services under primary healthcare are preventive. Preventive in nature. So hindi siya magmamahal. Actually, magiging affordable.
Mas magiging affordable.
Kasi, for example, a part of that prevention will be screening, right? So ideally, it should be part of primary healthcare. So it will now be more accessible, like a cervical cancer screening. I'm not sure if it part siya ng package. But in many countries, that's what they do. Some preventive services are in their primary healthcare. But obviously, there are population interventions like population programs to increase health literacy. Those are funded by your local governments, etc. So, but some aspects will be funded under that primary healthcare. So, hindi siya magmamahal. Actually, it should be more accessible.
Okay.
Yeah,
yes, ma'am. Go ahead, po.
Just wanted to add, because this is also one of our discussion points yesterday, no? In terms, PhilHealth also has a plan to increase its case rates. So we told them, how do you ensure that the support value is actually going to increase rather than just the difference just going to a higher cost? So to the point of how do you put that cap to make sure that any increase in computation, any increase in case rates will redound to more people being covered or to a wider breadth of coverage rather than just making the businesses of the facilities more profitable.
Yeah, thank you. That's a good point, Ma'am Karen. No? Speaking of primary healthcare and preventive care, we have people on the ground, health workers on the ground, whom we can easily tap, to do that. And I'm talking about our barangay health workers or BHWs, no. And I think it's very important to capacitate these people because they really work on the ground. They really work directly with the populace, no. So any thoughts on that point, no? And would you know of programs for our barangay health workers and other workers working directly with working in the communities? Dr. Val and Victor can also chime in if he has anything to say.
That's a very good point, no? Because when you talk about a primary care, Ma'am Sheila, it's the provision of services ng mga clinics, RHUs, etc.
Yes.
So we need to capacitate our barangay healthcare workers, primary care physicians, nurses sa communities. No? So again, I think there are challenges when it comes to healthcare workers issue on salaries.
That's right.
So may mga regulatory issues ka and challenges on that front. Ibang usapan yung workforce, but there are regulatory challenges and financing issues that we need to fix, no? Including improving the quality. We need to educate them, part of that. No? But
that's right.
But yeah, so kapantay ng expansion is to really capacitate our healthcare workers.
And given that healthcare is a devolved function, so malaki yung role dito ng ating mga LGUs.
Correct. Because there's salary. There's salaries from salaries from local government.
From local government. And I saw one of the questions ating chat box, no. I think it's also from Sheila May Almaza. She was talking about, how to better utilize, the additional resources from the implementation of the Mandanas ruling, no. To improve the delivery of health services on the ground.
Correct. May study tayo sa PIDS pero hindi pa nare-release. So tinignan namin kung may Mandanas ruling ba mag-increase yung spending natin on primary healthcare. Yung mga local governments natin. Palabas sa datos na mukhang hindi. Right? Kasi kung ibibigay natin yung pera sa primary, kung dadami yung pera ng mga local governments to spend for many things. No? Magbibigay ba sila sa primary healthcare? Magbibigay sila pero konti lang. Yun yung lumalabas sa datos. So, yun yung tingnan natin ng mabuti whether the Mandanas ruling will really translate to higher PHC spending. And wala pa tayong robust na analysis. No? So, yun yung malaking challenge, no? When it comes to the Mandanas ruling. Will they spend more for primary healthcare? We're not sure.
Hopefully, that is our hope. No?
It's our hope, but the existing data says na mukhang hindi. So because they want to spend for other stuff, right? There is limited resources then. They will spend for education, etc. No?
Okay. Thank you, Val. And Victor, would you have anything to add before we go to Ma'am Karen?
Yeah, sure. Thanks for this. Again, I think the point of the last few comments there was it's really about enablement. It's making sure that not only are the people on the ground or everything top to bottom and even on the lateral level, kailangan encourage sila to do what they want to do. So whether it's on a salary perspective or maybe even on a creativity perspective. Because this is where one point earlier that was mentioned, and that's also critical, yung digitalization. So there's this, especially during the pandemic, it was emphasized how to do all of these things. Pero we have to always look at it from a bigger picture, as in it's all about not just about trying to make things digital, which is another aspect in itself. We have to look at it as a journey from digitization, as in converting our data from manually recording, which is kind of menial in some ways, but also difficult to maintain, and then converting that to digitalization, which is another complicated process on its own, because it's all about converting your processes, not just the data, into digital platforms, into something that can be easily accessed and easily
Yes.
extracted later on. And then the last part of that is digital transformation, wherein your entire pipeline from collection to process to gaining insights to policy making to impact generation, right? So whatever consequences you want to have, those are all things that have to be thought of even from the beginning. So even if you have to change small steps along the way, there's a big picture goal na, okay, ito yung gusto kong gawin. Ito yung gusto kong gawin. So what I'll do is I will do all of these tiny steps, digitization, digitalization, digital transformation, and then you'll have to let the people who work on it embrace that. So one example nga yung sinasabi earlier about the feedback mechanism. So how can we actually get information from that? Another is getting information about the capitalization rates and the impact of certain rulings and things of that nature. Those will have to go back to the marriage, the synergy between policy making, questions you want to answer, business and domain expertise, and then of course the data that will back it up. And ang last sinasabi ni Val is, yung data doesn't say this way or walang data to capture it. And that whole journey that I mentioned will actually help with doing something like that. So there, thanks.
Thank you very much, Victor and Ma'am Karen.
Well, just to say that barangay health workers are really key contributors, no, to primary health care. They actually serve also as patient navigators. And when we talk about patient navigators, we're not just talking about helping patients access the right doctors or access the right diagnostics, but even financing. In many cases, they're able to direct the patients to additional sources of funding like PCSO, either the office of the mayor, the barangay chairman, etc. No, so this kind of knowledge circulates around the circle of patients. Even in Papo, we get to know when the beds are coming, who congressman or mayor or senator gives financial subsidy. So these barangay health workers are critical, except that many of the challenges is really capacity, right? They have so much on their plate. So many programs are being expected for them to know and to be implemented. So that's my sharing.
Thank you very much, Ma'am Karen. Well, what a lively and engaging discussion we just had. I will not belabor the important points shared by our speakers, but instead, may I ask them for some brief final words, if they have any, starting with Dr. Ulep.
Thank you, Ma'am Sheila, and thank you again for for mounting this event, no? And obviously, I would like to thank our discussants, so Dr. Albert, Dr. Karen Villanueva, Congressman Gato. Also, I would like to thank our co-authors, Dr. Victor, Jana, Isa Flaminiano, no, and Vito, no. So, I think ang masasabi ko lang, this is one of the first studies that we've released, using the data set na we tried to assemble. So in the next few months, we'll be doing more studies, to inform policy using this data. I think it's high time to use these kinds of data set to inform policymakers, more targeted approach, a more nuanced analysis. It's not all about averages. Because if you look at the Philippines, it's so diverse. There are challenges across provinces. There are limitations across geographical location, challenges across population. So we need to look into these challenges at a more granular and nuanced. So I hope this study, kahit una pa lang, we want to encourage more researchers to do more analysis like this. No? So I think ang goal lang naman namin is to actually start this kinds of analysis, no? Because we need policymakers to inform them, no? With more nuanced evidence. No? So I think yun lang yung masasabi ko. So thank you again for mounting this event, Ma'am Sheila. So
And thank you to Dr. Val Ulip for accepting our invitation to you and your team to present your study in our webinar series. And Mr. Victor Antonio, would you have anything to say as part of your
Sure.
closing? Yes, please.
Thank you. Val actually said most of it, but I think what we want to sort of encourage everyone to do is to always look at things in light of whatever goal you have. The reason for that is because we want to not only be able to solve current problems, but also we want to have that impact things not just on a data level, not just on a people level, but really bigger things as a policy level to future-proof everything. We want to ensure this study was really designed as a jump-off point for future studies to be made, for future actions to be done. So always look at things in light of the goal. If there are things that you want to do, there will be a lot of work that will need to be done, whether under the hood or talagang nakikita siya. So it's really just a matter of putting all of these components together, going through the rough patches and making sure that at the end of it, despite all the enlightening discussions, very lively and emphatic back and forth, we come up with actionable insights, and that's really what we wanted to do, and that's something that we hope to continue to share with everyone. Thanks.
Thank you very much, Victor. And Ma'am Karen Villanueva, please.
So first, I'd like to thank the PIDS team, for really championing evidence-based policy making. I think the challenge is to be able to advocate that our policies will really be based on what the evidence and the data shows. Of course, we all know that everything is political, but having seen this data and having other stakeholders exposed to the data will make it easier for our policymakers, or will convince them to embrace whatever data and policies we need to put in place. I think this is so important because, as mentioned, universal healthcare law was passed in 2019 and it's 2023, and the people can no longer wait. The burden of NCDs is really growing exponentially, and we need to be able to move quicker and faster. And the quicker and faster we can harness the data so that we can all together help PhilHealth navigate its directions, the better it will be for all Filipinos. So congratulations to everyone, to your hard work, to your advocacy. Just call on the patient groups in the event that you need our perspective. We're happy to participate. We're happy to co-create and to join you in finding solutions and to raise our hand on whatever we can do in terms of health literacy, information, and communication. Thank you.
Thank you
Ms.
very
Karen,
much.
as always.
Thank you very much, Ma'am Karen, and to the rest of your PAPO team. Maraming salamat po. And we also thank Congressman Gato of the House of Representatives and Dr. Albert Domingo of PhilHealth for joining us. So at this point, please help me in acknowledging and thanking all our speakers by giving them a virtual clap. Okay, maraming salamat, and I now turn the floor over to our MC, Ms. Sasa Esguerra. Sasa, over to you.
Thank you so much, Dr. Sheila, Dr. Ulep, Dr. Victor, Dr. Domingo, and Miss Karen. Your discussion is truly enlightening. I must say that today's word of the day is undoubtedly thought-provoking, because the author's presentation, along with the invaluable insights shared by our discussants, have truly been exceptionally thought-provoking. All right, so as we are about to end our program, let me announce the winners in our raffle draw for today's webinar. From Facebook, we have Jomar John Atensio of University of Eastern Philippines. And from Zoom, we have Abigail Madalo from Blonde State University and Adelito Posas of Palawan MMG MPC Hospital. All right, congratulations, and kindly check your inbox for additional details on how you can receive a small token of our appreciation for your participation today. Our team will be in touch with you shortly. Thank you again, everyone, for joining us today. All presentations from the speakers will be available on the PIDS website. We value your feedback, so please take a moment to fill out the feedback form that you'll find on the screen and in the chat box. For those asking for certificates, a certificate of participation will automatically be sent to your inbox after you submit the feedback form. Your comments and suggestions are invaluable in helping us improve our future events. All right, and please stay connected with us. You may regularly visit the PIDS website and follow us on Facebook, X, and YouTube. For the next month, please mark your calendars because we have more exciting webinars to come, okay? So on November 9, we have an on-site or face-to-face seminar titled Investigating the Determinants of Development Projects Performance. This will be held at the PIDS Conference Hall here in Quezon City. On November 23, we will have another webinar via Zoom titled Unlocking the Potential of Interlocal Cooperation for Efficient Urban Service Delivery. This will be via Zoom as well. And then finally, on November 29, SERPI will be conducting its annual symposium in Quezon City. Okay, so finally, we'd like to extend our gratitude to various organizations from the government, academe, CSOs, and other international organizations, private sectors, and the media for joining us today. We hope that this webinar has not only fostered discussions, but also set the stage for meaningful dialogue, ultimately working towards ensuring more equitable access to healthcare services for us all. Maraming salamat po, and we'll see you on our next webinar. Magandang hapon po muli sa ating lahat.